Oh yeah, same for the whole class.
Okay. Thank you.
I wonder if I should tell people. I'm just going to send an announcement out just in case.
Mine just kind of came up as it like it still was open or something when I went to Google for some, it just was right there. And I clicked on it. I don't know. You know how technology is, though.
Actually, I have to go into the announcements to get it, to retrieve it. And I use it for multiple classes. All right. Yeah, I'm hitting record. Okay, so first thing, for those of you that want, I'm going to do yeah, let me let more people in. For those of you that want, I'm going to do a study session on Friday at, I don't know, I guess 10. All right, we'll leave it at the same time. And that's not to say I can't do another one on Saturday or Sunday or any other day of the week. So, yeah, I don't know. I should just probably have that available to go over things and to go slower because sometimes I'm going fast. Like last class, I went kind of fast through the heart anatomy. In fact, I didn't even do it. Yeah, I'll record it and I'll post it. Every time I go on, unless it's like with like one or two, like if one of you asks me, hey, can you show me something? I'm not going to record that because that's kind of private. But like I'll record every class I do, everything, like, study sessions, everything. Yeah, I'll record it. I'll post it. Yeah, if no one comes, I'm going to do it anyway. And I'll do it myself and then I'll just post it. What else? The exam, they were at extremes, right? I had like A's and F's. So, so what I'm thinking about is exam. All right, so failing quiz 1 isn't going to do you in, right? If you failed quiz 1, it's not to, or if any of you got, hold on. All right. So doing bad on quiz 1 is not going to sink your grade. Doing bad on exam 1, it won't sink your grade, but it makes it really hard for you now, and it puts a lot of pressure on you on whatever's left over, right? But definitely possible. So, but I think I'm going to let you retake those of you that need to, that pass it, I'm going to let you retake it. But a couple things. One, I'm breaking. God damn it.
Your video was a little blurry, but then now your audio is starting to break up a little.
Unbelievable. All right, I'm going to put my phone back on because that seemed to work. I'm just going to do that right now. Unbelievable. And we still got people coming in too, so. All right, let me see if I can switch this. All right, so I'm just going to have to use my phone from now.
You're frozen.
Am I back?
Yeah, you're back.
All right. Let me put this somewhere. Well, I guess here I've got 4 bars. That's weird. Okay, let's see if that does any better. Yeah, okay, thank you. So yeah, I'm gonna let you those of you that bombed exam 1, I'm gonna let you retake it, but keep in mind it's gonna be proctored. And you need to do well. You need to like raise your average. So you're going to have to first do better on exam. So what I'm going to do is when I let you do the retake, I'm going to let you do it at the end before we take the final exam, because the final exam is going to incorporate questions from like all the chapters. So that'd be a good time to do it actually. So it'll be like it'll force you to study a little bit. So anyway, I'll let you do it then, but you have to get your average up. You can't like get D's and F's and then retake that. I mean, there's no point in it, first of all. So anyway, that's my plan. I haven't thought it through a lot, but I'm going to let you guys make up exam 1. So those of you that need to, but a lot of you did well on it. And so, yeah. What else? I think we could just start going, right? We're on the heart. I went in kind of assuming that you knew the blood flow through the heart, and so that you knew the chambers and the 4 valves and some of the bigger vessels. So, that was all the anatomy. And now I'm jumping into the physiology. If you are still messed up on the anatomy or still have questions, we can go over all of that Friday. Or to even today, it doesn't matter. Let me share my screen. All right.
Also, your audio is ahead. No, your video is behind your audio. How's that sound?
Video's behind the audio.
Yeah, they're not in sync.
Okay, so I'm going to have to go slower or give more time. So there's 3 types of circulation. Let me go back. 3 types of circulation with the heart. The first is called systemic circulation, and that's where the blood goes from the heart to all the tissues in the body and back to the heart again. That's it. So the blood leaves for example, if we're following it on this slide, the blood will leave the, aorta. So the blood leaves through the aorta. It goes to everywhere in the body, through all the arteries, and then back through all the veins, and then back to the heart again, through the vena cava. So that's systemic. Then there's a circulation up here, where the blood leaves the heart and goes to the lungs and goes back to the heart again. That's pulmonary circulation, right? So you just ask yourself, where's the blood going? Is it going to the lungs? Pulmonary circulation. Is it not going to the lungs? Systemic. It's going everywhere else. There's a third type of circulation called coronary circulation. Like you see, I'm like underlining the word. It says like here, left coronary. Coronary circulation supplies the myocardium with oxygen. So in other words, the heart muscle needs to also get blood because it's a muscle just like any other organ. So it needs oxygenated blood. And you would think that we would pull it from like the inside, like why doesn't the heart just take some of that oxygenated blood like inside a ventricle? I don't know, it doesn't though. So what it does is that here's the blood coming out through the aorta, right? So right before here where my cursor is, this blood, so follow my cursor down, it was in the left ventricle. So here it is in the left ventricle, it gets squeezed out, it goes through the aortic valve, and now it's in the aorta. So what happens is that's what happens when the heart contracts. So when the ventricles squeeze, it pushes the blood out this way. And when the ventricle then relaxes, that blood tries to flow backwards and go back into the heart. but it cannot do that. What it does is that it closes the semilunar valve, the aortic valve. It closes it, and then the blood, what happens to the blood is that, so you see this red line right here? That's the coronary, to one of the coronary arteries. And it's attached right to this aorta. So right at the bottom here, and it's kind of hard to see, but right at the bottom here, there's that coronary artery. So when the blood tries to flow back in, so it's flowing back in, it hits the closed valve, and instead some of it goes into this coronary artery. So there's a big one here, and there's one right here on this other side, the left side. And if you were to follow this through, so like we're following the arrow, here it is. Now it's kind of disappearing. It runs back here and it taps in here. So there's like two little arteries tapping into the aorta. So it's the right coronary and the left coronary artery. And so when you follow those two arteries, they feed the entire heart. Right, so that's all the blood vessels that feed the heart with blood. So we call those coronary arteries. I'm not going to make you learn them. You might have to in a different class, but we're gonna skip it. I just want you to know the right and the left coronary artery, and that's blood that feeds the heart. This is where heart attacks are. Right, if you're going to get an MI, myocardial infarction, it's going to be in one of these little ones. Right, you're not going to get a clot in this. I mean, a clot is not going to damage this thing. It's probably, although, there are cases where it does, but it's probably not going to stick in one of these, your carotid or your subclavian. That's not where you're going to get plaque buildup and a restriction of blood flow. These are too big. First, you're going to get in one of these little ones, one of these small coronary arteries that feed the heart itself with oxygen. So this is the flow of oxygenated blood. And I think my next slide, this is all the blood coming back. Right, so right next to these red ones, there are these blue ones, right? And so all of these coronary veins are going to converge, and they all converge. You see, like right here, it's hard to see, but there's like this right here is called the coronary sinus. And that empties into the right atrium. So there's three things actually that dump into the right atrium. There's the superior vena cava. And right now the heart's flipped around backwards, right? So you're looking at it backwards. There's the superior vena cava. There's the inferior vena cava. So that comes in from the top. The inferior vena cava comes in from underneath. Those are both dropping deoxygenated blood into the atrium. But there's also the coronary sinus. So if you were to open up the atrium and look down inside, you'd see like a little dot, right? You'd see like a big vessel that you could probably stick your pinky up in. That would be like the superior vena cava. And you could do the same for the inferior. You could probably stick your pinky in it. But then you see like another little dot on like the wall of the right atrium. So that would be the third thing that goes in, the coronary sinus. So that's the coronary system. It's the blood going from the heart to the heart and back to the heart. It's kind of weird. But it uses the same system as it would for any other organ. So that's the coronary system. Okay, let's go back a little bit to muscle physiology. Am I breaking up? Does that seem to be working any better?
I mean, I was looking at the picture, so I wasn't really watching you.
Did I all of a sudden not talk for like 20 seconds?
I didn't notice. No.
Okay, so I think my phone is really weird. Fiber optics not working. Phone with T-Mobile, nonetheless, seems to be working great. Whatever. Okay, so this is the The heart muscle itself is kind of like skeletal muscle when you look at it, but there are some key differences. The heart the heart has to all contract simultaneously. So when you look at the heart, the atria contract and then the ventricles contract. So it kind of looks like that. Top part of the heart contracts, bottom contracts, then they all relax. Top, bottom, all relax. Top, bottom, all relax, like that. So when the two atria contract, they have to contract at the same time. They got to all go 100% participation. You know, with your, let's say your biceps, when I go to lift this coffee up towards my mouth, I'm not using all my bicep muscles. So it doesn't have to go at 100%. It only goes a little bit. And then if I try to lift something heavier, my muscles will recruit other muscles and then they'll go 100%. If I'm lifting something that I can't possibly lift up, then I'm using all my muscles. The heart's not like that. It's got to go at 100% or 0%. So it has mechanisms to allow the electrical impulse to move through the heart really quick. And so they are called intercalated discs. So if you look at this photo up here, see where it's all like jaggedy right here? That's the wall of one muscle. And then here's the wall of one cell. And here's the other. So this is all one cell right here. I'm kind of going like in a circle around it. It's called a muscle fiber or muscle cell, right? So in the muscle, we call the cells fibers. So this is one muscle fiber. Here's one right here. That's one muscle fiber. And then here's another one here. So and this is the gap in between them or like where they fit in together. Right. And so those are called intercalated discs. They have like see the little holes here called gap junctions. So they've got like little holes, and that lets the electrical impulse go from one fiber to another one almost simultaneously. Right. So that's what our other muscle doesn't have. Heart muscle, that action potential. And action potential is like, imagine like the electrical impulse, right? That's got to like go through our heart really, really fast. So our heart muscle is a little bit different. To do a review, you should know what makes heart muscles contract. And you were supposed to get this last class in A&P1. I'm not sure if you got it. I'm just going to discuss it really quick. So you have like a heart, you have three main electrolytes or three main minerals that your muscles use to contract. They're sodium, potassium, and calcium. Sodium, potassium, calcium. Sodium, potassium, and calcium are all charged. They're all what we call cations, right? They're all positively charged. I don't have this. You know what? I do have this. There it is. So let's talk about that. Let's do this one now, and then I'll move back. So you have three cations. They're all positively charged. So something you should always remember about these cations or these electrolytes, because that's what they are. They're electrolytes. They like to hang out in different places. So when you look at where electrolytes hang out, you should look at your body as being two domains, inside your cell and outside your cell, because different minerals like to hang out either in your cells or outside of your cells. So we call that intracellular or extracellular. So if we're talking about muscle, there are some minerals that are hanging out inside the fiber or the cell, and there's some that are hanging out outside of the fibers. That's where they tend to like to be. Sodium is one that always likes to hang out outside of cells. It's extracellular. So they call it an extracellular cation. Cation means positively charged. So sodium's always positive. Chlorine's negative. There's negative ones, but sodium's always positive. Sodium always likes to hang out outside of cells. So sodium is an extracellular cation. Potassium likes to hang out inside cells. So we call potassium an intracellular cation. You're going to have this in other classes, in other lectures, when you talk about things like renal function. You're going to have all this, right? It's a very common thing to discuss. So, yeah, so let's think about like our muscle cells or muscle fibers now. So you have potassium inside and you have sodium outside. That's where they're hanging out. They're in about equal amounts. So if you were to all look at all the pluses, all the positively charged things inside your cell versus outside, it's about equal. They're about balanced. So there's about an equal amount of potassium inside of your cell versus sodium outside of your cell. So the positive charges are about equal. So the first thing that's going to happen is that there's special doors in your muscle fiber, and they're going to open and they're going to let all the sodium rush in. So before we had a balance. We had like a polarization. We had potassium on the inside, sodium on the outside. They're about equal amounts. Now all the sodium is going to rush into the muscle fiber. So now now you have all the positively charged things inside the muscle cell and nothing's on the outside. That's what creates the electrical impulse. So if you look here at number 1, they're calling it rapid depolarization due blah, 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 blah. What they're saying is all the sodium's rushing in and it's no longer polarized. They're no longer equal on both sides. Now you have all the positive charge things inside the cell. You've depolarized the muscle cell or the muscle fiber. You've depolarized it. Right? Electrically speaking, you've thrown it off. And so that's good. That's what starts the electrical impulse. And so that's what you're seeing here with number 1. You're seeing depolarization. Why did it happen? Because sodium rushed into the cell or into the fiber. Right? And that's what number 1 is saying. It's saying that there's a bunch of these gates for sodium. They opened up, sodium rushed into the cell. Don't worry about these millivolts. So it rushed in. That's going to cause the cell to contract, or the muscle fiber. It's going to cause it to contract. So contraction is caused by, initially, sodium rushing into the cell. So now the muscle fiber contracts. Calcium. So here's sodium. You see how it says Na+. Here's calcium. It says Ca2+. It just means Ca+. Remember, the plus or the minus all has to do with like electrons. Like, did you lose electrons? You're positive. Did you gain electrons? You're negative. But so don't worry about the 2+, but just that calcium's also a cation. So calcium starts to trickle in to kind of hold that contraction. Because what's happening is that sodium and potassium, they're like a married couple. Now I'm saying this like quieter. They're like a married couple. Like, they work really well together to do tasks together, but they don't like to hang out in the same room at the same time. So as soon as sodium enters, potassium's like, yeah, I gotta go to work. So potassium's starting to make its way to the door. They do a great job raising the kids and everything, but they like each other. They just don't like to hang out with each other. So as soon as sodium comes in, potassium starts making its way to the door. All right, so potassium's starting to leave now. So what's the point in having some positive charged things come in when some other positive charged things are starting to leave? right? So what happens is potassium comes in through the back door. I'm sorry, calcium comes in through the back door to kind of hold that contraction. You want to hold that depolarization. So that's what they're saying here. They call it a plateau phase. You're maintaining depolarization. So calcium comes in to hold that depolarization. Then eventually enough potassium, that's what the K plus stands for, enough potassium leaves. And so now they've kind of switched places. So now all the sodium's inside of the cell and all the potassium's outside, and now it's repolarized. So the muscle fiber starts to relax again. So they've ended up essentially swapping places. Right? So sodium enters, that makes it contract. Potassium starts leaving. But that's okay because at the same time, calcium's trickling in. And so it kind of offsets, it mitigates the potassium's leaving. But eventually the calcium stops coming in and all the potassium leaves. And now you're at a point where the pluses, the cations, the positively charged, are equal again on the inside and the outside of the cell, and therefore the muscle fiber relaxes. I know that sounds confusing. I need to probably make another video on it. Does anyone have any questions on that? So if you look at 1, 2, and 3 up here on this slide, then you'll kind of see. So depolarization refers to, and repolarization, they refer to electrical activity. But when depolarization happens, you're going to think in your head, okay, the next thing that's going to happen is contraction. And when repolarization happens, the next thing that's going to happen is relaxation. So depolarization causes muscle contraction. Repolarization causes muscle relaxation. And you'll see why, and now you can see why electrolytes are so important. And you see here's calcium. Right? We talked about hormones regulating calcium and pulling calcium out of your bone. And that's why, because it's used in the plateau. So we really need it to make your heart beat. This is what's going to make your heart contract. So these three electrolytes, and all electrolytes are minerals that we use like a lot, right? Sodium is part of salt, and calcium we get from whatever, milk, And you always hear about potassium, people talking about eating bananas and stuff like that. All right, Gatorade, that's what Gatorade is. They're just sticking these electrolytes in. So anyway, that's how an action potential starts and moves through the body. So this is what like an EKG is measuring. It's measuring this electrical impulse. This is showing kind of how this action potential spreads through the heart. So it doesn't all happen at once. That would be horrible. It has to have a rhythm. It has to have a place that it starts, right? It starts with a pacemaker, and then it goes in a certain direction. And you can kind of see how it's going here. It's starting. All of it is starting in the right atrium. So it starts in the right atrium, and if you follow it, it's coming down here. We call this the ventricular septum, right? The divider between the two ventricles. So it's starting here, it's going down in between the two ventricles, and then they're both coming up we call this bottom part the apex. They're both coming up around the apex and going to the side. So you see, if you follow this, the atrium are going to contract first. And then that electrical impulse is making its way down to the ventricles, and then the ventricles are going to contract. But it moves really fast. So as you see, there's 5 different parts to it. The SA node, that's the pacemaker of the heart. So when people get pacemakers, their SA node is all jacked up. So the SA node, then it moves to the AV node, atrioventricular node. That is right down here. So now we're kind of at the area, we're kind of almost at the junction between all four chambers. So there's the AV node. Then the action potential is going to move down the ventricular septum. So right here, it's called a bundle, an AV bundle. So these are common things to go to have problems in, right? It's common to have what we call like a bundle block. So if you ever hear of a bundle block in the future, that's what's happening. Something's wrong in here. Either it could get blocked, or you could make a lot more of these branches down here, and you could have too much electrical activity. But more likely, something's going to be blocked. There's going to be not enough electrical activity, right? So in any event, SA node, AV node, bundle branches. So this is called the bundle of His right here, or AV bundle, however you want to call it. Bundle branches down here in the septum. And then as it comes around here, this is your worst word, it's called Purkinje fibers. So that's how it goes, right? It just goes like this. Like if you follow the arrow, that's how an action potential goes, just over and over. So just like that. So I mean, that's it. That's how it works. Check out the myocardium on the left side of the heart. It's a little bit thicker than the right, by the way. So why is this myocardium thicker than this myocardium? Just something to like think about to yourself. I mean, you can answer it if you want, but you can answer to yourself too. So I know you're not big on participation.
Well, it's got to get the blood down to the feet, so it's got to have
Gotta get your blood down to the feet.
lungs. Unless the lungs are diseased, then it's going to go up.
Yeah, the right side's going where? Next door to the lungs. That's not a big deal. Right side's got to pump blood. I'm sorry, the left side's got to pump blood all the way down to your pinky toe. And more importantly, it's got to power that return trip back up to your heart against gravity. I mean, that's a pain in the ass. So that side works a lot harder. So you'll hear about things like, for example, mitral valve prolapse, but you rarely hear about tricuspid valve prolapse. You know, and not that it doesn't happen; it happens. It's just that cardiologists don't. You know, they're more likely to just watch it, and it's not as big of an issue for them because, okay, so your right side's not working as great as it should. That's going next door to the lungs. You know, it'll probably be able to make that trip. You know, it's like your car has bad tires. Okay, you're driving up to the grocery store, big deal. You'll make it, but you're not gonna, you know, you can't drive to New York. So that's like the left side. So anyway, these five here, SA node, AV node, I want you to know the order that it's going in. You know, it's going down the ventricular septum into the bundle branches, curving around the apex, making the Purkinje fibers. Any questions on that? And any questions on this slide? It's important you know how an action potential is initiated. Right? And you should know that these, and you should also know, like, just as a permanent thing, you should know the relationship between sodium and potassium. You know, the potassium's always intracellular and sodium's always extracellular. Like that's their natural state. And you should also start learning by this point what minerals are cations versus anions. Right, so you should know what's naturally, you know, if I say chlorine or chloride, you should automatically think in your head that it's an anion, right? That it's negatively charged. And sodium, you should automatically think in your head Na+, right? It's positively charged and it's extracellular. All right. So there's your EKG. It's a very standard, typical EKG. They don't look like this in reality. This is kind of an idealized one. They're much harder to read. But there's 3 parts to it. So this is measuring action potential, right? Some people mistakenly think that this means contraction or relaxation, right? In fact, down here they're saying atrial contraction, ventricular contraction. That's not exactly right, because this is measuring electrical activity. You can infer that the electrical activity is going to result in systole, or a contraction, but I mean, this is what it's measuring. So there's 3 parts to it if you look at it. So I'm going around the first part of it right here. There's like a P wave. Now I'm going to go around the second part, QRS complex. So where it kind of comes up and goes back down and goes up again. QRS complex. There's the third part, T wave. So P wave, QRS, T wave. And by looking at, so let me go to the next slide really quick. This is what it stands for. P wave is atrial depolarization. That means the atria are getting depolarized. They're about to contract. You're going to assume that you're going to have contraction of the atrium. QRS complex. Now it's the ventricle's turn to contract. So you're going to have ventricular contraction, ventricular depolarization. Then the T wave is ventricular repolarization. And you might ask yourself, well, what about atrial repolarization? Like, where's that? You don't need it, because while you have ventricular depolarization, you're having, when the ventricles are contracted, the atrium are going to be relaxed. So this is actually 3 stages of the cardiac cycle that we're going to talk about. The atria contract, the ventricles contract, the whole heart relaxes. That's pretty much the 3 stages. And when you look at a heartbeat, that's what's happening. The top part beats, contracts, the bottom part contracts, the whole heart relaxes. And that's what these 3 waves mean. But really, again, we're talking about electrical activity. And so when you look at different things, you can kind of like figure out what's going on. If it were like, I don't know, tachycardia, it would be like this QRS complex would be, there'd be like a bunch of them going up and down. If you have an elevated ST segment, like this little part here, if this were like raised up, that could be like indicative of an MI. Like, I can't read these things. I can read a straight line across, asystole. I'm good at that one. And then after that, it becomes really difficult for me.
If you ever see, like, when patients come in and they give them that the medicine, the clot buster, at ST segment, like, goes from way up to like normal again, it's just impressive. It's really a good teaching tool.
Really?
Yeah, I mean, just to see the difference,
Yeah.
It's impressive.
What's a clot buster called? TPA?
Yeah.
What's that stand for?
Yes, yeah.
Tissue plasminogen activated.
Tissue plasminogen activators. Which word of that? I was asking my wife what the clot busters were, to like bust clots. So she told me TPA, and the P stands, I just answered my question. The P is plasminogen. Plasminogen? Yeah, plasmin. All right, anyway. So the ST segment goes up when you give that?
Yeah, it goes way up.
Oh,
It's
wow.
way, way up there. It's like as high as where that ST word is. It goes way up there.
I know when this QT interval goes like longer, like when you see this QRS complex kind of drawn out a little bit, that could be indicative of like a PE. But I mean, I'm sure, Judy, if you know any of these, like if there's any of these you want to talk about.
There's a great book that I learned a lot about EKGs, Rapid Interpretations of EKG. And that is like just a perfect book to learn the bones, basically, none of that fancy extra stuff, but it tells you so much of what you really need to know practically, and gives you a lot of information on the different rhythms and the different blocks, the bundle branch blocks and stuff like that. And you can see a lot of, looking at an EKG and trying to say if it's where the heart attack is, if it's anterior, posterior, that kind of stuff. You can look at it and kind of get a quick glimpse. Now, doctors, when they get into certain things with bundle branch blocks, they get a little more technical because now they got the EP lab, and that is amazing because they'll take that little section that's like the bundle of His part, and they'll expand it out and say exactly where, like when people have atrial fib, and they'll say exactly where that spot is, that's the problem, where they want to ablate, where they want to burn it to stop them from atrial fib. And it's like super expensive equipment. They lock it up. It's amazing. And it's a really super hard thing for anesthesia to do because they want them not intubated, but they don't want them to move, and then they don't stimulate them, and then they do stimulate them. So it's a hard challenge for anesthesia to take it. And they usually overweight, and they don't like laying flat. They don't want to be still, so, but it's amazing the technology of what they know about that now, how they look at that little bundle of His part, so, whereas in the old days, it was just the EKG, so that's another really interesting area.
The dangerous thing with EKGs nowadays is that they're telling you on the top what they think the problem is. So you'll see it'll say bundle block on it. And so you don't have to necessarily read the EKG. I'm sure, I know a cardiologist is going to read it, but yeah, I mean, that's their job. But
it's pretty accurate, but the doc has to put the signature on it and kind of make sure everything is kosher, that kind of stuff.
And they're really good at it. I don't know how they do it. And I know paramedics and EKG techs, they know all this as well, even though they won't tell you, and they're full of it because they know all this. There's hundreds of different readings. They're
right. But it's just you see it so much, so you just kind of learn it. Yeah.
Yeah, I can, and you got to look at it from this isn't the only one. You're shooting different, depending on how many leads you have, but you've got two up here, and then you usually have a bunch down here, and then also there's ones that you might have on your shoulders or your arms, and depending on how you want to hit the heart, right? So it will change.
It's like taking a picture of a building in 5 or 6 different areas, that's basically what that is.
There's a whole class on it. I think Katie, she's Katie. I don't know. I forgot her last name. Slipped my mind. But she teaches a class on this. It's kind of interesting. That's the whole class, how to read these, how to place the electrodes. But what I want you guys to know about an EKG is that. I want you to know what the P wave means, what the QRS complex means, what does the T wave mean, what does it represent. And I wrote it out. That's it. That's what it represents. So, any questions on EKG? So this is all physiology. And so for the semester, if you see me talking about something on physiology, that's a very likely question. I don't ask a lot of anatomy questions. Most of the questions are going to be physiology. I want to know how the heart works. I could really care less where the mitral valve is. I'm just assuming you know where it's at. So far today we've talked about 3 or 4 things. We've talked about this. So this would be a possible question. the no, you're right. I don't know, I forgot what to call it, but this is the order of the action potential. And Judy was talking a lot about right here, the bundle of His, and we were talking about like the bundle branches, and she was talking about ablation, like burning cauterizing different areas in here and stopping impulses from going. So I want you to know this order. I want you to know what it is that makes a muscle contract. This you should have had last in Fastlane 1. And if you did, it's the same idea, because the heart is ultimately a muscle, right? So the same idea. So that, and then the third thing was the EKG. So the fourth thing is a little bit more difficult. It's the cardiac cycle. And in my opinion, if you know the cardiac cycle, then you kind of know, you'll have a good idea about the other things that we've already talked about. I mean, you have a real good idea of the heart if you understand the cardiac cycle, not memorize the cardiac cycle. This is going to take you all day to memorize, you're like, oh, depolarization of atrial contractile fibers produces P wave. I don't even know what that means. And then you just memorize all this. That's not going to, you don't understand what's going on. I want you to understand what's going on. And I summarized it here in about 3 slides. Your book has it in 6 steps. And if you look at your book, they've made it really super complicated. They've written out what happens in each step. So it's like a whole page, or maybe it's a couple pages. I've tried to break it down. The cardiac cycle is all the events associated with one heartbeat. You notice here that they're talking about seconds. This last point whatever, 200 milliseconds or 0.2 seconds. For me personally, I don't care about that. I don't care if you don't put any of that, right? So unless you're really, really getting into it, the time is not going to be, unless you're working for like a cardiologist or you're in cardiology for some reason, time's not going to be like a major thing. But knowing how the heart's working, that is important. And there's lots of videos on this. If you just put in cardiac cycle, again, I'm going back to Khan Academy for these particular videos. So they're the better ones that I've seen. So there's 3 parts to it. I've broken it down into 3 parts. And actually, they're these same 3 parts you're seeing here. I've broken it down into the atria contracting, which corresponds with the P wave, the ventricle contracting, and the whole heart relaxing. So there's words for, let me see if they're on here. Yeah. So there's words for contraction and relaxation. Diastole means relaxation. Systole means contraction. So those words are used. So when we break it down, we have atrial systole, meaning atrial contract. Then after the atrium contract, then it's a ventricle's turn. So atrial systole, then ventricular systole, then relaxation. Those are the 3 steps of the cardiac cycle: atrial systole, ventricular systole, relaxation. The whole heart relaxes. Top part contracts, bottom part contracts, whole heart relaxes, top, bottom. I can't coordinate my hands, but just watch a video. Okay, I got to do it now. Oh, I'm doing it. All right. So anyway, that's atrial systole. So we're going to talk about some of the events that happen in each part. So I broke it into 3 parts. Your book has it broken into 6 parts. So there's atrial systole. It's a cycle. It's like a circle, so there's no start, there's no real start place, and there's no real end place. So what's happening is that right now the atrium are relaxed, they're getting ready to contract, and they're filling up with blood. In fact, I just made a mistake here. No, this is right. Okay, so the atrium are filling with blood. There's a valve underneath it. So the atrium's filling with blood. There's a valve underneath it. Like imagine like a trap door in the floor. And when you get enough weight on that door, that trap door is going to pop open and you're going to fall down to the next floor. Sort of like that, right? That's your AV valves. So blood's coming in from like the vena cava, from the pulmonary veins, whatever side it's on. Blood's filling up the atria. And so at some point, it's going to fill the atria, and the pressure of that blood is going to get enough where it opens up those AV valves, and it's going to open like a trap door. And all the blood's going to drop, not all, most of the blood's going to drop into the ventricles. So we call that rapid ventricular filling. It just means that blood filled the atria, it got full, it opened the two AV valves, and all that blood dropped into the ventricles. Most of it. But as I put down here, 25 milliliters of blood is still left in the atria. And I'm telling you here ventricular diastole. So the ventricles are relaxed, right? So because the atrium's getting ready to contract. You're never going to have, shouldn't say never. You're not supposed to ever have the atrium and the ventricles contracting at the same time. Right? So if the atrium are going to be contracting, definitely the ventricles are going to be relaxed. So that's what I'm saying. The blood had just dropped into the ventricles. Second one, the ventricles are relaxed. Third, not all the blood made it into the ventricle. There's still about 25 milliliters of blood left in the atria. So now the atria is going to contract because it wants to push the rest of that blood into the ventricle. So that's number 4. So now that most of the blood dropped in, there's about 25 mils left. We want to contract it, the atria, and push that blood into the ventricles. So I'm telling you here that the AV valves are open. And if the AV valves are open, most of the time the semilunar valves are closed. So the ventricles relaxed, the semilunar valves are closed. And now you have, at this point, when you push that last 25 mils of blood into the ventricles, there's some blood in the ventricles. But how much blood? Well, it's around 130 mils. But that's not the number is not important. What it's called is important. End diastolic volume, or they just call it EDV. So it's the volume of blood in the ventricle after, while it's relaxed. So we're really talking about the ventricle. What's happening with the atrium? Well, they're contracted. And they push the blood into the ventricle. Well, how much blood is in that relaxed ventricle? That's end diastolic volume. So that's all what happens with atrial systole. So during atrial systole, you get an end diastolic volume. The 130 is not critical. If you put 120 or something on a test, I'm not even looking at your number, to be honest. I want to know what end diastolic volume means. I'm not looking at 25 milliliters. I don't care. I just want to know some blood's left in the atrium. Most of the blood drops into the ventricles. It builds up. The AV valves open up. That blood drops into the ventricles. How much exactly? It changes. And then how much blood ends up in the in the ventricles, that's end diastolic volume. And the word diastole, that refers to what's going on in the ventricles, obviously, because the atrium are in systole. All right. Probably should have just shut up and made it less confusing. Let's talk about the next one. Now it's the ventricles' turn to contract. Right? The atrium have just contracted. Now it's the ventricles' turn. So first thing, you're going to have atrial diastole. The atrium are going to relax. When the ventricle contracts, think about this. When the ventricle is going to like squeeze all that blood, and there's like a lot of pressure going on in the ventricle when you're squeezing it, that blood's got two ways to go. There's two doors. There's an AV valve going back up, and there's a semilunar valve going out. One door opens out, one door opens in. The AV valves, that opens into the ventricle. So when the blood tries to go back up into the atria, it closes those doors. It closes the AV valves, right? Because it's a one-way door. It only opens in. So when you try to push back, it's going to close the doors. Therefore, the blood goes to the semilunar valve and pushes on that door. That door opens out and the blood leaves. So that's why I've written AV valves close, semilunar valves first open. The blood leaves. Not all of it. Even after the heart pushes out, even after the ventricles push out all the blood, there's still some blood left over. And so, look what I did. I wonder if you guys saw my mistake. So then you have an end, not diastolic, and systolic volume. Because I want to know how much blood is in the ventricle after it's contracted. So what's the volume of blood at the end of ventricular contraction? At the end of ventricular systole, how much blood's left over? And so we've got like these two numbers now. How much blood was in the ventricles before it contracted? How much blood is in the ventricles after it contracted? And we can figure out how much blood got pushed out. So there was I'm just using numbers that the book tends to give. This number could change, but this is like a very typical type of number. 130 mils before contraction. There's 70 mils after contraction. That means 60 milliliters of blood got pushed out of the heart. So that's stroke volume. In other words, stroke volume is how much blood's getting pushed out of the heart when it contracts. Or how much blood's getting pushed out of the heart with each beat. I mean, that's what stroke volume is. And at the end of the day, that's what we're interested in. We want to know how much blood's getting ejected from the heart. There's something similar to that called ejection fraction, which is probably more commonly used. Ventricular systole, AV valves closed, semilunar valves open, blood gets pushed out of the ventricle. We have an end systolic volume. And that's the second part. Third part is relaxation. The whole heart is going to relax. So this is the T wave now on the EKG. This is like the third part of it. So relaxation, the whole heart is relaxing. The atrium and the ventricles are relaxing. So during this time, it doesn't mean that there's no activity in the heart. No, the atrium are filling with blood. So this is kind of bleeding back to the beginning. The atrium are filling with blood. They're starting to fill. So either it's coming in from the pulmonary veins or the two vena cava. Right? The AV valves are closed, but eventually enough blood's going to get on them that they're going to open. Right? Once the atria fill with enough blood, the pressure is going to open those AV valves. But at the same time, the blood is flowing backwards. The blood that just left the heart when we had a ventricular contraction, that blood that just left, as soon as those ventricles relax, that blood turns right around and tries to come back. But it cannot, right? It closes the semilunar valves. And so you actually have a small fraction of a time where all 4 valves are closed. The AV valves are closed, and blood's filling the atria. Blood's filling the atria, but the AV valves didn't quite open yet. And the blood that just left the heart tried to turn around and come back in, and it closed the semilunar valves. So you've actually got a little small period of time where all 4 valves are closed. So we call that isovolumetric relaxation. There's an isovolumetric contraction too, but anyway, isovolumetric relaxation. All 4 valves are closed for a brief second. And then we start over again. We go back to atrial systole. Right, the AV valves pop open, the blood drops into the ventricles, and we're back again. So, it's not like this slide is like the end of cardiac cycle. I know it's a lot of stuff. This one's kind of difficult. You just kind of have to picture in your head what's going on. That's why watching lots of videos of it would be helpful. They're trying to show you here. I think it's like horrible. The green is supposed to be the I don't know what even, I don't know. I can't figure it out. But this is essentially, I've broken the 6 steps down into 3. Step 1, step 2, step 3. By the way, stroke volume is not necessarily part of step 2. I added it, like I thought this was a good place to tell you what stroke volume was. So, step 1, step 2, step 3. Anyone have any questions? Oh, I've gone over that. I'm gonna go a few more minutes because I'm actually almost done with this. Like this was like the hardest part of it all. Like I don't have anything that's like as detailed as this. Let me just make sure you're still here. You are, okay. I can't see you guys while I'm presenting, so I might be talking to nothing and I don't know it. Cardiac output. Cardiac output is your stroke volume times however many times a minute your heart beats. That's it. Stroke volume is how much blood is getting ejected from your heart in one heartbeat. And then multiply that by a minute. That's cardiac output. Cardiac reserve, which I'm not going to ask you about, is just telling you that, what's the difference between your heart, like at total rest when you're sleeping or something, and then at its maximum ability. So your heart could work 4 to 5 times more efficiently, when you're in a sprint than it does when you're like sleeping. I'm not going to ask you about it. Cardiac output is used. I've seen that used. But again, stroke volume. Oh, another mistake. Stroke volume times, I got to fix that. Stroke volume times beats per minute. Oh, bugs the shit out of me. All right. This is probably, I've got 2 more things to talk about. This is my last slide. Oh, almost my last slide. Regulation of stroke volume. So what can make that stroke volume, in other words, blood that leaves the heart, what can make it more or less? And there's 3 things, there's 3 factors that contribute to the regulation of stroke volume, and I've written them here. So, preload. Really, we're talking about the ventricles here, not the heart, right? So your book says the heart, but we're talking about the ventricles, the amount that the ventricle stretches before it contracts. So the more you can stretch the ventricle out before it contracts, the more you can stretch it out, the more you're going to have leaving the ventricle. So like a water balloon, right? If you fill it with the balloon with water, the more you could get into that balloon, the more it's going to come out, right? So the more you get that balloon to stretch out, the more water is going to come out if you let it out the other end. Then contractility, the forcefulness of the contraction of the ventricle. How hard does that ventricle contract? The harder it contracts, the more blood's going to get pushed out. By the way, that's what norepinephrine does. We never talked about them. We just talked about epinephrine, and then I put norepinephrine, and I said what they do together. Norepinephrine increases contractility, increases the forcefulness of contraction. And then you have afterload. So you have a pressure that builds up in the ventricle before the semilunar valves can open. So blood's filling up and it's blood's filled up, it's contracting, it's like squeezing. How much do I have to squeeze it? How much pressure do I got to put on those semilunar valves before they're going to pop open? That's afterload. So the more pressure I can build up, the more like explosion you're going to have, like the more forceful the blood's going to come out. So it's the pressure how much pressure can you build up in that ventricle before the blood gets ejected? That's what regulates stroke volume. Very last thing I'm going to talk about, and we will be done by 11:15. One way or the other, I will finish it. Regulation of heart rate. So there's two factors that we need to look at. One is the nervous system, your brain. Your brain regulates your heart rate, and chemicals can regulate your heart rate. And what do I have in my notes? First, I have your brain. So look here. It's saying sensory receptors. So you have little receptors all around your body, and they're measuring all sorts of different things. Just like you have pain receptors, you also have something called proprioceptors. They're monitoring the movements of your limbs. Like right now, my heart's beating faster because my proprioceptors are getting triggered. Heart beating slower. Faster, slower. I gotta watch a recording of this. Faster, slower. I had to do it a lot so you get the idea. So it's monitoring limb movement and changing your heart rate based on that. Chemoreceptors, monitoring chemicals, monitoring like the pH of your blood, or something more applicable, monitoring, for example, how much carbon dioxide's in your blood. So if I have too much carbon dioxide in my blood, the chemoreceptors are going to pick that up. And I want to increase heart rate because I want to increase respiration. I'm going to try to get rid of it. Baroreceptors are monitoring pressure. So if the baro meaning pressure, if those baroreceptors pick up that blood pressure is low, how do you think that's going to affect the heart rate? Yes, it is. Whatever you're thinking. It makes it go faster. So you're going to compensate. So the receptors pick up, they send a message up to your brain. Your brain sends a message down to your heart. How does that message get from your brain to your heart? It's already on here. One of those cranial nerves. And out of those 12 cranial nerves that I imagine Mr. Waddell made you learn, here in this chapter, 10. Cranial nerve 10, the vagus nerve. If you remember, all those other cranial nerves stop probably around here. Most of them are in your head, neck, tiny bit shoulder, maybe your accessory nerve, but one of those goes further and it goes down to your thorax and even a little bit to your abdomen, and that's the vagus nerve. So And then remember, well, I don't know if I'm assuming you learned this, sympathetic and parasympathetic. It's really easy. Sympathetic is fight or flight. Parasympathetic, rest and digest. The act of going to the bathroom, that's parasympathetic, where you've got time to do that. You just think, what do I need if I'm being chased by a wild bear? Do I need to go to the bathroom? Is that critical to my survival? No. Parasympathetic. How about digesting the food that's in my stomach? No. What I need right now is energy to my leg muscles so I could get the hell out of there. That's sympathetic. Parasympathetic would be everything, most everything else at that point. So I got a little bit off topic. These receptors, yes. The vagus nerve, I would like you to know that. So that's plugged into your heart. Your cardiovascular center is here in your, I think your medulla oblongata, down in your brainstem. And the other end is hooked up to your heart. Now there's chemicals as well that can mess with your heart rate. We've already talked about them. Epinephrine and norepinephrine. Right? So epinephrine speeds your heart rate. Norepinephrine, we'll just put them together. Epinephrine and norepinephrine increase your heart rate and contractility. Well, heart rate, all right, we're talking about heart rate. Epinephrine increases your heart rate. But there are cations. There are those, remember we talked about sodium, potassium, and calcium. That's not their only job. What we talked about like a few slides ago, the fact that they can go into your cell and they go out of your cell and they make your heart. They have other jobs too. They can act like hormones by themselves. So sodium and potassium, if you treat them like a hormone, they're going to decrease heart rate. So this has nothing to do with what we were talking about earlier with the action potential. This is they've got different jobs. They've got their full-time job, and then they've got a bunch of side gigs they do. So this is like a different job that they do. Sodium and potassium decrease heart rate, so they can slow your heart rate and contractility. And calcium can speed up and strengthen your heart rate. So and there's another hormone that your heart makes called ANP. We'll talk about that later. But okay, that was a lot today. Did I do it? Oh, I didn't. Then I lied and I went to 11:17. We're done. I'm going to do a study session on Friday, and I'll do any other one that you want as well. Let me stop sharing. Good, you're still here. Let me stop recording.